Good morning, good afternoon, and good evening, everyone, regardless where and when you are watching this lecture. And I'm the Medical Director of Clinical Development at Akebia Therapeutics, a small drug development company developing novel for anemia of chronic kidney disease. I'm also a faculty director in the postgraduate medical education department at Harvard Medical School, faculty at the Department of Epidemiology at Johns Hopkins School of Public Health. I would like to thank Dr. Ashish Goel, colleague to me, for the past 4 or 5 years for inviting me to give this talk to you. I'm going to talk about confounding in epidemiologic research. And before I begin, I would like to that I am an employee of a drug development company. I did not receive any compensation for this talk. It is to be declared relevant to this talk. I'm going to talk about two things, something called DAGs, or directed acyclic graphs, and confounding. I'm going to start with the definition of the directed acyclic graph. These are graphical displays of causal relations in which each variable is assigned a fixed location on the graph and in which each directed causal effect of another variable is represented by an arrow with its tail at the cause and its head at the effect. It seems in a couple slides, I'll show you why this is really important. The component of the DAGs, one, the arrows display the relationship. Acyclic, it means that an effect cannot cause itself. These are graphic representation of relationships between variables. When do we use DAGs? Study design to organize exposures and outcomes, to identify confounders, which is why I'm this talk today, and identify what information to be collected, and also during statistical analysis research project to identify which confounders to adjust for. And here is an example. Has an exposure variable that causes hypertension, at least that's what we hypothesize, are associated with cardiovascular disease in a causal manner. But in the meantime, the relationship with more complex than we think. There's also hyperlipidemia and diabetes that are that have interrelationships with, but also old age has a causal effect to hypertension and cardiovascular disease. If I'm studying the directed acyclic graphs in these relationships, I'm looking here at obesity as an exposure, outcome hypertension, but hypertension as an exposure can also be a cause for cardiovascular disease. Cardiovascular disease, hyperlipidemia for cardiovascular disease. This DAG is shown from one of my own research studies that I have done in India many years ago, and the SEEK stands for Screening and Early. And in this graph, I was trying to identify what variables that I should adjust for in my analysis. Here's chronic kidney and obesity, diabetes were the main exposures, and then I was trying to study other variables that I should adjust for and take into account when studying this relationship. Well, let's go to confounding. Let's first define what is a confounder. Excuse me. Distortion of a measure of the effect of an exposure on an outcome due to the association of the exposure with other factors of the outcome. Sounds complicated. Let's try to simplify it. Remember this association between cardiovascular disease, hyperlipidemia, and diabetes to all and old age associating with all these. So in order to make simpler, let's take a look at directions. The confounding can be positive confounder, which is basically overestimating two variables, or negative confounding, which underestimates the effect between two variables. It could also be qualitative, means reverse the estimation of effect. So if you have an association that is not adjusted for confounders, it could be protective to the outcome. But when you adjust for one or more confounders, the association that would be the exposure or increases the outcome. So what are the features of a confounder? Confounder must be associated causally or non-causally with the exposure, must be causally associated with the outcome, and must not be an intermediate step in the causal pathway between the exposure and the disease. You can remove here the word disease and say, so must be associated causally or non-causally with the exposure. So here, for example, obesity and hypertension. Similarly for hyperlipidemia and diabetes, hyperlipidemia and obesity, hyperlipidemia and cardiovascular disease. Age with cardiovascular disease and old age with hypertension. Must be causally associated with the outcome. So here we can look at hyperlipidemia and cardiovascular disease for the and cardiovascular disease. And hyperlipidemia for the association between diabetes and cardiovascular disease, it's also causally associated. And then lastly, must not be an intermediate step in the causal pathway between the exposure and the outcome or the disease. This association here, or makes this variable instead of being called a confounder, it would be called a mediator. So let's take a look here. So hyperlipidemia is associated with diabetes, excuse me, associated with cardiovascular, but not in the causal pathway from diabetes to cardiovascular disease. Then hyperlipidemia is a confounder to the association between diabetes and cardiovascular disease. But let's take a look at the association between obesity as an exposure and cardiovascular disease as an outcome. Hypertension is causally associated with is non-causally associated with hypertension, and cardiovascular disease, and hypertension is in the causal pathway between obesity and cardiovascular disease. This makes hypertension not a confounder, a mediator. Looking at the association between hypertension and cardiovascular disease, either a confounder or a mediator, it's associated with the exposure, associated with the outcome, and indeed not in the causal outcome. This makes old age confounder to the association between hypertension and cardiovascular disease. Define confounders. We have a knowledge-driven approach by knowing all the clinical relationships between all the and outcomes being collected, as well as other confounders being collected, knowledge of public health relationships, and literature. Also conceptualization similar to the whiteboard schematic diagram that I showed you earlier from my 6 study. Confounders could be also due to through data-driven approach, which is identifying associations within own study, association, which I will get to it in a few. So in comparing the knowledge-driven approach in identifying confounder, the knowledge-driven approach consider multidimensional nature of confounding, and the data-driven approach may confirm association. The knowledge-driven approach is always based on the body of evidence that the clinician or the researcher knows, but the data-driven is what you see in your own analysis. The knowledge-driven approach requires your own judgment as a researcher, but the data-driven judgments if conditions are predefined. The knowledge-driven approach are not easier to report, but the data-driven are easy to report. The knowledge-driven approach, you use the literature or your own judgment, which may not have a specific evidence base for your. The knowledge-driven approach decision is separate from own data, but the data-driven approach, we use statistical significance testing, which is a poor guide to identify confounders. The knowledge-driven approach risk of over and under adjustment, but in the data-driven, there's always risk for manipulating the analysis. You may remove confounders or add one or two confounders just to make your main association statistically significant, which is not appropriate. So generally, identifying confounders, believe it or not, is a collaborative effort among all the team members in the research team. This includes clinicians as well as statisticians. Now, how do we can control for confounders in the study design stage and through something called restriction, and I will get into all these in a second, or optimization, or we can control for confounders during the statistical analysis stage, which includes adjustment, called standardization, or stratified analysis, or sensitivity analysis, or multiple regression. So this paper was published in the American Journal of Epidemiology in 2010, and it looks at mortality in the nurse health study. So what this study did is that because they identified gender as a confounder for mortality, for the association between any exposure and mortality and death, they excluded all men from female nurses or female gender in this analysis. And that's how they controlled for confounder in the study by restriction. One of the pros of restriction is that we control for confounding, and it is built into the design of the study. So it minimizes the bias confounding. But the cons of restriction, it slows down recruitment because if you're doing something similar to what they did, you basically exclude half of those people that would have been eligible into the study if you did not exclude all males. The applicability of results beyond the study, because we know that if there is a variable that is a confounder to such association and you exclude it to one gender versus the other, then you limit the applicability of the results to the males, as using the example that I. What about in the study design stage, how about matching? So here in this paper that was published in 2000, Occupational Health, a case control study looking at the working hours and cardiovascular disease in Korean workers. And what they did, they did a matching between the cases and controls using several key variables. Of the paper, they identified the control group was recruited at 4 occupational health institutes at university hospitals. Controls were based on gender, age up to 5 years older or younger, type of occupation, and region using the methods. Workers were contacted through a group occupational health service or health examination. So the moral of the story here is that because they identified gender, age, type of occupation, and region, key confounders to the association between working hours and cardiovascular disease, then they matched using these few variables. That's how you exclude or you remove or control or adjust or take into account, which is the same. You adjust for the confounding effect of all these variables on the association between working hours and whatever you are measuring at the end in the association between working hours and cardiovascular disease using this designed matched case control study, purely based on the association between the exposure and the outcome after excluding the confounding effect of the variables that you matched up. In this case, gender, age, type of occupation, and region. How about randomization? Simply randomize. I can give you an example from any randomized clinical trial that is published. I just decided to show you this prevention of cardiovascular events and death with pravastatin in patients with coronary heart disease and broad range of initial cholesterol levels. This is adjustment can also be done at the statistical analysis stage to control for confounders. Now, is that you may have missed or the study design is not appropriate to control for confounders using the 3 design stage, which is restriction, matching, and randomization. So what you can do is you can do standardization, which I'm not going to, it's beyond the scope of this talk, or you could do stratified analysis. For this example, I'm using a paper that was published here in Circulation, Cardiovascular and Cardiology journals, and this was published in 1999, so almost 20 years ago, 21 years ago. There are effects of pravastatin on plasma concentration of C-reactive protein. Interestingly enough, Paul Riddicker, Mark Pfeffer are leaders in the area of cardiovascular disease and lipid management. What these authors did, that in table 4, they presented the main results by looking at the change in mean C-reactive protein concentration over 5 years of follow-up according to assignment. Let's take a look at the anatomy of the table over here. The first column includes all the variables, the number of subjects included in that specific analysis, and then here, the change in CRP concentration over time using liter units. You have the placebo, then pravastatin, then the net difference between the two, and the p-value for the difference. So using the stratified analysis, after they presented the main results, which is the of negative 0.137 and statistically significant difference in the placebo versus pravastatin arm in the. They also did stratify by subgroups of age, subgroups of BMI, subgroups of smoking and non-smoking, blood pressure measurements, both systolic and diastolic, subgroups of LDL cholesterol, HDL cholesterol, as well as triglycerides. A third way to control for confounders in the statistical analysis stage using analysis. So here I'm presenting the main paper that I published in 2012 for the epidemiology and risk factors of chronic kidney disease in India using the screening and early evaluation of kidney disease study that we did the DAG for earlier in this talk. So here we screened 6 subjects and we analyzed about 5,500 subjects, and then we analyzed the data to identify using the CKD epi equation and the CKD using MDRD equation. Here I'm presenting the baseline demographic and risk factors data for Seek India cohort. Here I'm presenting the data for all participants. Then I'm presenting the CKD status, CKD, non-CKD, using the MDRD equation, and the other one using the CKD epi equation. So let's take a look at how I conducted the sensitivity analysis using the CKD epi equation in this. So I stated here in the method section that we use the CKD epi equation in the sensitivity analysis to test whether it produced similar results. Using the CKD epi equation, the prevalence of the CKD was 16.4%, CKD stage 1 was 8%, and the one estimated using MDRD3. However, the prevalence of CKD stage 2 and 3 were 3.2 and 3.3 each other. And the CKD epi equation performed similar to MDRD3 in CKD stage 4 and 5. I'm going to pass on that. And then finally, looking at controlling for confounders at the statistical analysis stage using multiple regression. So if I'm going to ask which method should I use for confounding, I would say confounders problematic variables. And confounding is a problem that I should always look after and control for it at the study design. And if we're focusing on the outcome prevalence, I would use standardization. If I'm focusing on causal association, the overwhelming majority of the studies that you and I conduct, we either do sensitivity analysis or we do multiple regression, which I'll in details in another talk. We could also do stratified analysis only if you have large sample size enough. So in summary, I presented to you the directed acyclic graphs and confounding. I would end with the same paragraph Edward Hill ended his main paper, that he introduced the causal criteria, Hill's criteria for causality. That all scientific work is incomplete, whether it be observational or experimental. All scientific work is liable to be justified by advancing knowledge. That does not confer upon us a freedom to ignore the knowledge we already have, or that it appears to demand at a given time. Who knows? Asked Robert Browning, but the world may end tonight. On available evidence, most of us make ready to commute on the 8:30 a.m. next day. Thank you very much. And I'm very interested to receive your questions. And again, thank you very much, Dr. Ashish Goel, for to give you this talk. Goodbye.